Hello everyone. Let us discuss today about the excretion of drug, the last part of pharmacokinetics of drug. That is the last part of movement of drug. The drug has entered inside the body through site of administration and reaches systemic circulation and distributed into the whole body, and now it is moving outside the body, which is known as excretion. So elimination of drug from the body includes both metabolism and excretion. How the entered drug will be eliminated out from the body? Through elimination. Now what does it mean? Elimination. What is elimination? Difference between elimination and excretion. Elimination includes both metabolism as well as excretion. So it is the way of eliminating the entered drug outside the body. That is known as elimination. So elimination includes metabolism as well as excretion. Metabolism we discussed in the previous video. That is, it is the conversion of the active form of drug into the excretable form. Now the next step is excretion, and both combined together known as elimination. Now excretion of drug. The drug will be excreted out from the body by means of renal excretion and non-renal excretion pathways. So, renal excretion means excretion of drugs by kidney, whereas non-renal excretion means it includes other than the kidney organs responsible for excretion, like salivary excretion, skin excretion of drug, pulmonary excretion of drug, or milk excretion of drug, or biliary excretion of drug. So, the excretion other than the route used by kidney. Why renal is kept on the other side? Because most of the drugs, about 90% of drugs will be excreted solely by urine or partly by urine. That is renal excretion. So, most of the drugs excreted by renal excretion, and other than renal routes, that is non-renal routes like biliary, salivary, milk excretion, pulmonary excretion or skin excretion of drugs included in the non-renal excretion routes. Today we will discuss about the renal excretion. So renal excretion means excretion of drugs by kidney. With the help of kidney. Kidney is responsible for excretion of drugs. Such excretion is known as renal excretion. So renal excretion, it is not a simple process, it is a very complex process. Include three more processes, which is known as glomerular filtration, tubular secretion. So once you remember the tubular secretion, you have to include the word active. So first is glomerular filtration, second is active tubular secretion, and third is passive tubular reabsorption. These are all the three steps involved in renal excretion process. So the renal excretion process, which is a complex process, includes three steps in excretion of drugs as well as the components outside the body. So first step is glomerular filtration, second step is active tubular secretion, and third step is passive tubular reabsorption. So if you know, the structural and functional unit of kidney is the nephron. So the blood flow, it enters here, the glomerulus is there, so the drug urine will get filtered through this glomerulus, which is the first step, which is glomerular filtration. So through this, some drugs will be escaped through the blood vessels and may get again secreted from the tubules to the tubules that is present, from the blood vessel to the tubules. This is tubules. This is glomerulus. This is actually the structure of nephron. So this is glomerulus, which consists of a bunch of blood capillaries, and this is tubules, which consist of proximal tubule and distal tubule. Ultimately, they have a collecting duct where the urine will be collected and excreted out through the urinary tract. So this is tubules. Some of the drugs which escaped the glomerular filtration passes through the blood vessels can be again excreted through this tubule from blood vessel, and that is the second step, which is active tubular secretion. And the drugs which has been filtered from the glomerulus which enters the tubules again may get reabsorbed into the blood vessel. That is the third step, which is passive tubular reabsorption. The drug or the nutrient or any compound that has been filtered through glomerulus, when it enters the tubules, there are possibilities that these compounds can passively reabsorb again into the body. It will be circulated again into the body. So because of this tubular secretion, the drug or the components which is tubularly secreted will have less half-life because it is secreted to the tubules and it will be excreted out. Whereas reabsorption of drugs, that is tubular reabsorption, increases the half-life of the drug because it is again reabsorbed into the body and it is not excreted and it is not available for excretion and it is circulated inside the body. Thereby there is increase in the half-life. So glomerular filtration. First step is glomerular filtration. So when the blood vessels, again the glomerulus is the blood capillaries. When the blood vessels passes through these blood capillaries, that is about 25% of the cardiac output. So about how much is the blood volume? It is about 6 liters. So 25% of this blood volume, that is cardiac output, about 1.2 to 1.5 liters will be reaching the kidney. So the blood flow to the kidney will be about 1.2 to 1.5 liters. That is about 25% of this 6 liter. So in each day, for every single day, about 180 liter of urine or the blood will be filtered through this glomerulus. But are the whole 180 liter will be excreted out through the urine? Are we excreting 180 liter of urine every day? No. About 1.5 liter of urine will be excreted each day. So what happens to the remaining volume of the blood that has been reabsorbed? It has been reabsorbed. So the compounds that has been filtered through this glomerulus also has some specifications. The pores present in the glomerulus will not allow plasma proteins to pass through the glomerulus, as well as the blood cells also cannot be filtered through this glomerulus. They will be retained through the glomerulus and it will again enter into the circulation. So since plasma protein cannot enter through the glomerulus, even the plasma bound drugs also cannot pass through this glomerulus. So it cannot enter through the membrane. So the drugs, plasma proteins, blood vessels and the drugs which are plasma protein bound cannot filter through this glomerulus. So what is the glomerular filtration rate, which is known as GFR? GFR is the glomerular filtration rate. It is about 120 ml. It is about 120 ml per minute. So GFR means about 120 ml of blood will be filtered in each minute to have a glomerular filtration rate. How it has been determined? By using markers like creatinine and inulin, because these substances are endogenous substance which has been cleared off through this kidney solely. Mainly they are cleared off solely, that is only by kidney, as well as they are not protein bound substance. So this creatinine and inulin clearance will be helpful in determining this GFR rate. So how this 120 ml per minute of GFR rate is calculated or observed? It is from the creatinine clearance and inulin clearance. This is about glomerular filtration. Now what about active tubular secretion? What is this tubular secretion? Means secretion, the drugs which has been escaped through this filtration again enters the blood vessels, and once it moves to the tubules, there will be passage of drugs from the blood vessels to the tubules against the concentration gradient. That is why we have used the name active, because the concentration of drug in blood vessels will be more than that of tubules. So it is moving, tubules contains more concentration, and here there will be low concentration. Here the concentration of drug will be higher. So against the concentration gradient, the drug will be moving from blood vessels to the tubules. That is why it is known as active tubular secretion. So the drug which has been escaped from glomerular filtration, when it enters the blood vessels, sometimes it will move against the concentration gradient when it passes through the tubules. That is known as active tubular secretion. Because of active tubular secretion, some drugs will have clearance more than GFR value. So as it is active tubular secretion, it is not affected by plasma protein binding. As we already discussed in glomerular filtration, it is affected by plasma protein binding. That is, plasma protein bound cannot be filtered through the glomerulus. Whereas tubular secretion, even the plasma protein bound fraction also can get secreted through this tubules. So tubular secretion is independent of plasma protein binding. And also active compounds or the active transport mechanism again has one more specific criteria, that is they can be competitively inhibited. Like example of drugs which undergoes active tubular secretion is penicillin. Penicillin has active tubular secretion and it will be excreted very fastly from the body, and it has low or short half-life. So why penicillin is having short half-life? Because this drug is secreted through tubules and it will be excreted out easily from the body. So half-life is very less for this penicillin. But when you need a therapeutic activity for a longer period of time, you need a longer duration of action or longer half-life for a drug. So how to increase the half-life of the drug? By co-administering along with the acidic drug, which is probenecid. Now what this probenecid does, since it is competitively inhibited process, which process? Tubular secretion is an active process, so it can be competitively inhibited for the binding sites. So the carriers or the binding sites are responsible for binding of drugs, and it involves in tubular secretion. So like penicillin is bound with some carriers and it is tubularly secreted. Here, once you include or co-administer probenecid along with penicillin, probenecid will have high affinity for the binding site of penicillin and it will displace penicillin from the binding site, and the probenecid will bind with that carrier and that probenecid will get excreted, whereas penicillin will be circulated again inside the body, which will increase the half-life of the penicillin. So this tubular secretion can also be competitively inhibited. So active tubular secretion means it is movement of drug from the blood vessels to the tubules against the concentration gradient, and it is independent of plasma protein binding. And the third point to remember is that they are competitively inhibited. That is, example, penicillin is tubular secreted drug, because of which they have short half-life. So to increase the half-life of drug penicillin, you have to co-administer probenecid. This will bind with the binding site of penicillin and it will displace penicillin from the binding site, and it will increase the circulation time of penicillin and thereby increases the half-life of penicillin. Now, next process in this renal excretion process is tubular reabsorption, which is passive process. What is reabsorption? That is, absorption of drug, that is high concentration present in the tubules, will get reabsorbed again into the blood vessels and enter into the body again through this blood flow. How this takes place? Along the concentration gradient. As there is high concentration of drug in the tubules and low concentration of drug in the blood vessels, there is possibility of movement of drugs from lower concentration to higher concentration to lower concentration. When there is low concentration on one side, the concentration from higher side will move towards the lower side, which is diffusion. So what is passive tubular reabsorption? It is the diffusion of the drug molecules from tubules to the blood vessels along the concentration gradient, and it takes place passively. So all the drugs will get reabsorbed or what? No, the drugs which are lipophilic, mainly lipophilic and unionized drug will get passively reabsorbed through this from the tubules to this blood vessels, and reabsorption will increase the half-life. Tubular secretion will decrease the half-life, whereas tubular reabsorption will increase the half-life of the drug. Like glucose. Glucose has 100% absorption in our body. Why? Even the glucose which has been filtered out through the glomerulus, once it enters the tubules, it will again actively secreted as well as it will be reabsorbed into the body, and completely 100% of this glucose will be absorbed in the blood. So such drugs, some drugs also have tubular reabsorption, and it will reduce the glomerular filtration rate, because the clearance, that is about 120 to 130 ml per minute is the GFR rate. Once it enters, if the drug which will have clearance equal to that of creatinine clearance will have clearance of about 130 ml per minute. And if there will be tubular excretion, that is excretion of drug, secretion of drug from the blood vessels to this here, this will be greater than 130 ml per minute. And if the drug will be reabsorbed, then they will have less than 130 ml per minute as their clearance. Got it? So this is all about the renal excretion process. Now let me explain about the clearance. So clearance may come in short notes. So you must know what the clearance is, what the systemic clearance and renal clearance are. So first is, you have to study about clearance. So clearance, generally written as CL, so includes, it is known as systemic clearance. So how the drug or the component that enters the body is cleared off from the system is known as systemic clearance. This systemic clearance includes renal clearance and non-renal clearance. Clearance by kidney is known as renal clearance, and by the non-renal routes are known as non-renal clearance. Now what is the definition of this clearance? So to define this clearance, you must know the unit of clearance. The unit of clearance is ml per minute. So why I asked to remember the unit is that you can define the clearance by remembering this unit of clearance. How? The hypothetical volume of the body fluid. So unit of volume is ml. So clearance is the hypothetical volume of the body fluid which is required to clear off that substance or the drug substance from the body per unit time. So the unit of time is minute. That is why I asked you to remember that unit first. If you know the unit, you can define very easily. That is ml per minute is the unit of clearance. So ml is the unit of volume. So which volume? Volume of the body fluid. So hypothetical volume of the body fluids which is required to remove the drug substance from the system or the body per unit time is the definition of clearance. And it is the hypothetical volume, and it is cleared off by kidney. If it is with the help of kidney the drug is removed, then that is renal clearance. By means of non-renal routes, then they are known as non-renal clearance. And if it includes both, then they are known as systemic clearance. Now how to define? We have different methods of defining. Mainly 3 methods are there to define this clearance. So clearance can be defined as the ratio of urinary excretion rate to the plasma drug concentration. Notice this is the ratio of urinary excretion rate upon plasma drug concentration. So rate can be written as dx upon dt. So it is urinary excretion rate. So it is written as dxu upon dt. Xu is the amount of drug that is excreted in urine. So dxu upon dt is the rate which is excreted in urine. So urinary excretion and rate can be written as dxu upon dt upon plasma drug concentration is C. This is one method of defining this clearance. Using the same method, we can define it another way also. How? This dxu upon dt is proportional to x. So, this can also be written as equal to ke into, including some constant, ke into x. So, instead of this dxu upon dt, we can write it as ke into x. So, it can be written as ke x upon c, where we studied already volume of distribution. V is equal to x upon c. So, this can be written as ke into V. So, this is renal excretion. So, it can be written as renal clearance. But if it is systemic clearance, instead of ke, K will be involved. What is the difference between ke and K? Ke is the urinary excretion rate constant, where K is the elimination excretion rate constant. Just I discussed, elimination includes both metabolism and excretion. Here it includes only excretion, that too renal excretion. Here it is renal excretion constant. So this is another method of determining the clearance. It is the product of elimination rate constant into volume of distribution. So this is another method of explaining this clearance. There is another way by using the processes, renal excretion processes. So what are the processes involved? Glomerular filtration, tubular secretion and tubular reabsorption. So clearance, renal clearance can be written as the glomerular filtration clearance plus tubular secretion clearance into 1 minus fraction of the drug that has been reabsorbed. So what does it mean? So the drug which has been filtered, how much the drug will be excreted out through this kidney or cleared off through the kidney, which has been filtered and which has been secreted will reach the tubule and then into collecting duct and will be excreted through the urine. So which has been filtered and secreted will ultimately excreted out from the body. But the one which has been reabsorbed will be not excreted from the urine. So it is being subtracted, that is 1. It is the maximum in fraction. So like in percentage 100 is maximum, in fraction 1 is maximum. So total minus how much it has been fraction reabsorbed, that is included here, and which has been not reabsorbed will also get cleared through this urine. That is why renal clearance can also be defined like this: glomerular filtration that has been filtered and which has been secreted, multiply by that 1 minus fraction of reabsorbed. So clearance can be defined in 3 methods. Already I said creatinine clearance. So the endogenous substance creatinine is used. What is this? Creatinine is an endogenous substance which actually cleared off through kidney. Especially this has been excreted or cleared off through kidney and it has no plasma protein binding. That's why this can be used to determine the glomerular filtration rate. How much is the glomerular filtration rate? Is about 130 ml per minute. So the drug which is having similar clearance, that is completely filtered through glomerulus but not tubular secreted and also neither tubular reabsorbed. If the drug is neither reabsorbed nor secreted, just filtered, will have clearance of about 130 ml per minute. Whereas those drugs like penicillin already I discussed, it undergoes tubular secretion. So once the drug will be tubular secreted, that will have glomerular filtration rate greater than 130 ml per minute. It is about 500 ml around. It is more than 130 ml. So it is going beyond the clearance value. Why? Because it is not only filtered, it is also secreted. Filtered volume about 130 ml it is added, and additionally some amount has been secreted. So it has added the volume, and the clearance of this drug will go beyond the GFR value, that is greater than 130. And in case of another drug, phenytoin, this drug gets reabsorbed in the body. So its reabsorption will be more. So as the drug will be reabsorbed, the clearance will be less than 130 ml per minute. It is about just 5 ml per minute. Why less than 130? Because the 130 ml it has been filtered, but it has been reabsorbed. So remaining has been reabsorbed, and only left for clearance was just 5 ml per minute. So which will have similar to creatinine clearance, the drug which will have only glomerulus filtration, neither reabsorbed nor secreted, will have clearance of about 130 ml per minute. But once it is secreted, if the drug is filtered as well as secreted, will have greater than 130 ml per minute. That is in case of penicillin, and in case of phenytoin, it gets reabsorbed. So it will be reduction in the clearance of that drug. That is, it will be less than GFR, that is less than 130. Like in case of phenytoin, it will have only clearance of about 5 ml per minute. So this is all about the clearance. So once it has been asked for the short note, so you can define in different terms, and you can explain about the importance of the clearance of some drugs which will have similar to GFR value or greater than or less than, like using tubular secretion and tubular reabsorption. There is another marker which is used to determine the renal blood flow. So renal blood flow can be determined by para-aminohippuric acid. So what is this? PAH is para-aminohippuric acid. This is used to determine the renal blood flow. How much the blood flow? So I said in first initial classes that renal blood flow is about 25% of cardiac output. That is about 1.2 or 1.5 liters will reach the kidney. So how it has been determined? So the marker used was to determine is PAH, para-aminohippuric acid, which is again it is not plasma protein bound, and it is highly lipophilic, and it is not permeated through the membranes, not the blood vessels. It cannot permeate through the blood vessels or nor plasma protein bound, and also lipophilic in nature. So this marker can be used to determine the renal blood flow. So we discussed today about the renal excretion processes as well as clearance, creatinine clearance, and all the clearance, systemic clearance and renal clearance. In my next video, we will discuss about the non-renal excretion like salivary, milk, biliary excretions, and pulmonary and skin excretion of drugs will be discussed in my next video, that is non-renal excretion. Thank you.